a thought just came to me as I was listening to Richard this morning and his presentation. So I wanted to add a little bit more information about what really we're talking about when it comes to TB. So in terms of the impact of criminalization, I want to talk about the person first. What does it mean for that person? And we heard the really compelling stories yesterday, and you'll hear a few more tomorrow when we hear about some of the cases in TB. But one of the biggest issues is, of course, stigma. And Richard and Edwin yesterday also talked about this, where we are looking at stigma in terms of the person, when you're thinking about criminalization, and it deters the person from actually seeking out healthcare services. And this, of course, will include delays or avoidance of diagnosis or treatment interruptions that could lead to death. It could lead to drug resistance, unnecessary pain and suffering, and or further disease transmission. So, when I travel around the world and I talk to a lot of people who have TB, a lot of them who are HIV positive will actually talk about their HIV status, but will not talk about having TB. They refuse, because they feel the stigma is so much higher with having TB than it is with HIV. And a very well-known HIV activist, her son, who is also HIV positive, got TB. And he said, "Mom, please don't tell anybody." And yet he's very willing, he's a young boy, he's about 14, he's very willing to talk about his HIV status, but he didn't want anybody to know he had TB. So this is the kind of stigma that we're dealing with, including in a healthcare facility. So it's not just our communities, but it's also in the healthcare facility, because health workers aren't being protected from getting TB either. So stigma leads to discrimination in employment. We've heard about people who get fired from their jobs in healthcare settings, where I've been in clinics where they didn't realize I was there to look at TB, and they were actually telling people who had TB, "Go away, we don't want to see you." It also leads to discrimination in housing and education. It might also mean poor treatment, difficulties with adherence, and expulsion from the family or community. So we know in some instances where in the subcontinent, in India, Bangladesh, Nepal, that region, where women who are found to have TB are kicked out of the house, they are no longer allowed to see their children, or they're divorced. And so the experiences that they have are comparable to HIV, I would say, in the 80s and 90s, where we used to see that happen quite often. And the self-stigma and poor mental health. So we don't even deal with any of the mental health issues when it comes to TB, a lot of which come from the side effects from the drugs people are taking. But the self-stigma seems to be one of the greatest and most challenging areas in TB that we don't address. Criminalization also looks at when we're looking at the delays in people going for diagnosis, it means that they're infectious for longer periods of time. Poor treatment outcomes, which lead to death or drug resistance. We're talking about not being able to maintain the treatment regimens because they can be quite onerous, and because you're trying to hide taking the pills so that no one can see that you're actually doing it, which means that some days you might skip your pills. And when you skip your pills, this is where we get into issues around recurrence of TB, or we have the possibility of it becoming drug-resistant TB. There's also that negative impact on the health worker-patient relationship. So the person with TB and the healthcare worker, where there is no trust. And we heard from Karabo yesterday, where the first healthcare worker he went to just didn't believe him, didn't want to deal with him. And it took a second healthcare worker who actually listened to his story and then realized that this was a man who was sick and needed help. And that lack of trust seems to now have grown in our public health services in terms of TB. In a lot of countries, we see people who are now they will actually go miles out of their way in order to go to a place where no one knows them, a health facility where no one knows them, or to go to a private hospital or a private practitioner where they might not get the best of the care that they should. Healthcare workers and healthcare institutions become mechanisms of enforcement for criminal or other laws or regulations. So we have a lot of healthcare workers who will actually turn up at the person's door, at their house, in their car that says TB, this program from the lovely people of the American people or whatever the funding is, all emblazoned on their cars, in their outfits, in their t-shirts, in their stickers or buttons. And so that the huge issue we're dealing with is that there is no confidentiality in TB because healthcare workers will do this. They will go to someone's house to ensure the pills are being taken. And they're doing it from a place that's good, because they want to help that person to actually adhere to the treatment. But they don't realize that by going there and, with the big TB emblazoned on the van or their t-shirts and so on, that they're actually telling the whole community and that person's family that they have TB. This creates, perpetuates, or exacerbates stigma among health workers toward people with TB, which again results in poor treatment outcomes for people. So there's also a disproportionate and discriminatory impact on vulnerable or marginalized groups. And we mentioned this yesterday, but it's important for us to raise it again because I think Hajian, made a great presentation yesterday afternoon where she was talking about the interlinked nature of diseases and it being one person who might have several issues. So members of the groups are subject to law enforcement and prosecution at higher rates than individuals from wealthier, more politically powerful groups, often who are the majority. And I think the Carrie Thomas case and some of Richard's comments this morning attest to that fact, that those marginalized groups, those minorities, are much harder hit by discriminatory practices. If you look at indigenous people, for example, indigenous groups in terms of TB have some of the highest burdens. In some countries, they have 80 times more TB than the non-indigenous group of people. And we're not taking this into account in terms of our service delivery. Another example would be migrants and undocumented immigrants and some of the other key vulnerable and underserved populations we mentioned yesterday. And evidence shows that people living with HIV who are perceived as others have also been disproportionately prosecuted under HIV-specific or general criminal laws. And this comes from a book called Criminalizing Contagion. It's a fascinating book because they actually tried to talk about all the ways that we've been criminalizing diseases, and they don't mention TB at all. And so, I've written to the authors and asking why, because at the end of the day, if we're looking at this region, then TB and HIV are the deadly duo. And so in terms of the impact on the person, this is what we're really talking about with TB criminalization and what can happen to somebody. But I wanted to mention ethics, because we have been talking about laws and policies and guidance that are in place in countries. WHO has obviously put out a lot of guidance around human rights in HIV and other disease areas, but they haven't done it in tuberculosis. However, what they have done is they've put out a guidance on ethics and TB. And so they define this as ethics is concerned with what should or ought to be done. And this includes consideration of the way we ought to live our lives, including our actions, intentions, and habits. Obviously, due to cultural or religious differences, ethics can sometimes be a source of disagreement with people or conflict among people. But with careful analysis and debate between all the relevant stakeholders, it's actually possible to come to some sort of a consensus. And so this WHO guidance, I wanted to raise it because it actually begins to address some of the questions that we had yesterday afternoon. So who is responsible to protect and promote ethics and human rights when implementing the End TB strategy? The End TB strategy is the World Health Organization, the World Health Assembly, so all the governments of the world have agreed to this resolution that we will end TB by 2030. Yeah, we'll see. I don't know. But if we put into place certain measures, we have a good chance of doing that. But in this document, and so I have to say this up front, national TB program managers, anything that comes out of WHO in terms of tuberculosis is God. This is where they get all their policies and guidance from. And when WHO wrote who is responsible to protect and promote, they said the managers of national TB programs and those responsible at the subnational level. So when you are looking in your countries at who are the primary people who should be responsible for delivering a gold standard of care, these are the folks that you should be talking to. And this is in line with sound ethics and due protection of human rights as established in several conventions. I won't go through them. You guys know all these, the Convention on Economic, Social, and Cultural Rights, and a whole bunch of others, and we can actually put that into the resources where I've listed out all of the treaties and covenants that cover TB human rights. So the public health argument for protecting the public from people who have TB is really applied in a few ways. One is quarantine. And quarantine is where a disease control measure that applies to individuals who have been exposed to a communicable disease, but they're not yet ill. So this does not apply. You cannot put into quarantine people who have latent TB infection because we don't have enough quarantine rooms for 2 billion people. And we don't know who those 2 billion people are because it's quite difficult to detect latent TB in somebody. And I'm hoping that Dr. Boyles, when he gets here later, will be able to talk. Oh, and there he is in the back. Would be able to talk a little bit more, but I know, a bit of excitement this morning. I've been up since 4, so I'm on a roll already. It's like noon my time. So be able to talk a little bit more about some of the testing and how difficult it is to test for latent TB infection, active TB disease, and so on. Isolation is where we actually separate people who are sick and have a communicable disease, such as TB, from those who are healthy, and we restrict their movement to stop the spread of that disease. Isolation is the separation of public health officials generally may isolate individuals with TB disease if they pose a threat to public health. So this is what is out there. This is what people think is happening. But WHO has actually said that isolation and involuntary hospitalization should be the last resort. Respiratory isolation in TB management can take the form of physical isolation in hospital or a household. So here in South Africa, they have one of the model programs for actually doing home-based, community-based care for drug-resistant TB. In Eastern Europe, Central Asia, they will put people into a TB hospital for the duration of the time that they have drug-resistant TB. So that could be up to 2 years. And let me tell you, these are not normal hospitals. I've been in some of them in Kazakhstan where you go in, you have to go into the quarantine outfit, the blue with the helmet and the everything, and you come in and it's a locked door, and you go in and then there's a guard sitting at a door, and then you have to go into that one, and then each person is in an individual room that is locked. So they have it's like being in prison. And there's no need for that to happen. So when people are talking about hospitalization or isolation, we really need to question why they got to that decision so quickly. Is it ethical to ask people with active TB to voluntarily isolate themselves in order to to stop contagion? Absolutely not, because we can provide them with measures to stop them from transmitting the disease. So when is it unethical to isolate people with TB? If there is no, if the person is not contagious, or if isolation holds no clear public health benefit to the community, there is absolutely no need for isolation. And let me tell you, when you put someone into jail, you are not putting them into isolation with active TB disease. You're putting them into a prison cell with other people who may or may not have TB. So you're not actually adhering to any public health measures that make sense whatsoever when it comes to TB. Is it ever ethically acceptable to resort to involuntary isolation in the context of TB? For the most part, TB treatment needs to be provided on a voluntary basis. We need to have informed consent and cooperation, and this is where we differ from HIV. If you ask someone with HIV what their medicines are, why they're taking it, what the side effects are, for the most part, people can tell you why. They can name the drugs, they can name how much they're taking, when they're taking it, why they're taking it, and what the potential side effects are. Ask the same question of someone with TB. They can normally not name one single drug they're on because there have been no counseling and testing, no treatment literacy. They don't know why they're on it for 6, 9, 24, 36 months. They also don't know what the side effects are. So when they start feeling sick on the treatment, they stop. So there's no access to information. So if we're not providing all the information possible, then of course people might want to stop taking their medication. So non-adherence is often the direct result of failure to engage the person fully in their treatment process. Involuntary isolation should never be a routine component of TB programs, ever. I can't emphasize that enough. But there are those rare situations where it might be necessary, where you have made all reasonable efforts to help the person to adhere to a course of treatment, if they're unwilling or they're actually unable. If you have someone who might have a mental disability or someone who is elderly and might not be able to take that medication, then we need to be able to think about other measures that could help them. And then isolation would be that last resort. Unfortunately, I did want to mention one thing. WHO produced a list of priorities in 2018. So they produced this beautiful document about ethics, and they produced so this is this TB department in WHO, beautiful document on ethics. They're really trying to put out guidance that will help people to adhere to treatment, help programs to implement good service delivery. But then WHO as a whole has produced a list of priorities in 2018, and TB is not on this list. So a disease that affects 2 billion people, made 10.4 million people sick, and killed 1.7 million people in 2016, this is an epidemic under WHO definition, and yet it is still not on a priority list, which means that we in this room need to ensure it becomes a priority. So at the end of the day, what they're really saying is that politics will now kill more people than this disease possibly could, and that's not acceptable. And none of you in this room would be willing to accept that either. So I just wanted to put that out there and say you are also not just lawyers and people who are from the media and the other, what the other group? I'm the other group, yep. We are advocates, and the work that you do is advocacy on a larger scale than what you think on a daily basis when you go to work. Thank you.